All right. Again, welcome to the mental health and basic healthcare session. So we all know that mental health and basic healthcare are essential supportive systems for individuals who are returning to the community successfully. So as the dual physiological and the racial injustice pandemics disproportionately impact minorities and poor communities, collaboration within the community itself is essential to closing the gaps. So in this session, healthcare experts, Kelly Storm, who is the Behavioral Health Director for the Ohio Department of Rehabilitation and Corrections, and Perry Gregory, when he is able to find his way to our session, will provide an overview of the gaps exposed by the pandemics. They offer real-time guidance on effective collaboration to address the mental health and physical health of individuals in a continuum of care for returning citizens in our larger populations. So, Kelly, what have you been thinking about regarding issues of healthcare and mental health as it relates to the reentry population since the pandemic?
Yeah, Kysten, so thank you everyone for joining us today. You know, I think that it's so important that we have such great partners within ODRC and our correctional continuum that support our reentry. And so really we have been blessed, as the director spoke about this morning, to be able to actually leverage those and look at this pandemic as an opportunity to strengthen our efforts and not let it derail all of the work that we had kind of identified pre-pandemic. You know, we have really truly been able to engage our partners within OMOS, our partners within Medicaid, our partners within the community to really ensure that we're strengthening reentry and preparing our restored citizens for successful reentry into their communities. You know, some things that we kind of look at as we continue to try to stabilize is, you know, one thing that we need to be mindful of and really work to promote is explaining the new landscape of our communities to our restored citizens as they're leaving. You know, they have kind of gotten to know what it's like to pandemic within our facilities, but we need to make sure that they're prepared on what to expect in regards to being in the pandemic within their communities. You know, and some great things that we've done are we have partnered with Medicaid and the managed care plans on those reentry backpacks that the director spoke about this morning. We've reestablished a lot of our services to make sure that they're still getting all of their reentry needs. You know, but what we need to talk to them about is kind of like, what does behavioral health care look like in this pandemic setting in our community, and kind of getting them knowledgeable about what telehealth is, what that looks like, especially for individuals who have been incarcerated for long durations of time and maybe aren't as technologically advanced. We need to make sure that they have those skills and the knowledge to be successful so they can effectively link with their behavioral health care, they can effectively link with employment opportunities, with their healthcare needs, with reentry supports in general. You know, we want to make sure that we're doing that. And so we are taking some of those extra measures, we're doing some joint partnerships, and we're making sure that we're making those stronger connections for our restored citizens so they're prepared for what to impact. Because, you know, just like all of us, we're learning how to pandemic, right? And what that looks like for us working from home. You know, who would have ever thought, you know, we would be sitting here having this virtual platform and not be able to be together, but we're here and we're doing it and we're thriving because we've adapted and we've been given tools to be successful. And so just like we need those tools to be successful, we need to make sure that our that those individuals who are going back into their communities have the same access to those tools and the same knowledge about those tools so that they can effectively pandemic and maintain their, their mental health, maintain their sobriety, maintain their medical, health, and successfully reintegrate and be thriving members of our communities. And so I think that's really where we need to focus, is just remembering that they might need a little bit more help on accessing those tools and knowing how to effectively use those tools to be able to sustain in this kind of new normal that we're all learning about. And Kysten, I'd be happy if people kind of wanted to chat, since it is kind of, we're down one panelist. So if people also have ideas or want to give us feedback or engage in the questions, I am more than happy to kind of dialogue back and forth as well, as I believe that, we are a community in this, class setting right now. And I welcome that feedback or questions or ideas that people have, because it makes us stronger. We all together, we're stronger.
Absolutely. And as soon as I ask a couple of more questions, I will open it up for the panel. So One of the things that I'm interested in is, how is this, how has DRC and OMAS come together to teach individuals how to pandemic, if you will? It's easier to say we need to teach them, but what are some tangible things that have been going on in the institutions on helping people prepare for release and how to take care of their mental health and their physical health during a pandemic?
Yeah, so that's a great question. And so one thing that we've kind of done actually is we've kind of exposed them to it in a way. So when we were early on in the pandemic, we did have some utilization of telehealth on our end as we kind of cohorted some staff and things like that. So we had the incarcerated population have the opportunity to actually engage in telehealth and kind of learn the system. So it's not as scary and it's not as different to see someone on a screen and figure out how to develop that rapport. Also, we do mental health discharge planning with all of our individuals on the mental health caseload. And so we're talking to them about, what does that look like? We've talked to our staff about making sure that we're enhancing our care as well in our facilities. And so care has looked a little bit different on the inside. And so I think that that's a better way for them to know that care is going to look different on the outside, as well as providing them with that education, that knowledge. We're still doing our Medicaid pre-release and our managed care, engagements, but it's looking a little bit different right now. And so I think that because things are looking a little bit different on the inside, it's a natural progression that things are going to look different on the outside, but then providing them with those tools. The director was speaking about how we're working to get those cell phones for individuals. And I think that that's going to be so important for them to stay connected as we are all operating kind of in a virtual landscape right now. I'm confident that our OMAS partners are kind of working with, their patients as they get ready to, the ones with substance use disorder issues are getting ready to release, that they're also providing that education piece. And I think one-on-one education is important. And I know our education department is doing some work in this space as well. So I think it's kind of a little piece of every part of the puzzle, which is so large within DRC, working together and also working with our community linkage partners on ensuring that we're still engaging in linkage and telling that patient what that's going to look like. Is that going to be an in-person appointment? Is that going to be a telehealth appointment? Making sure that they have the connection. And community linkage happens for all of our seriously mentally ill offenders to make sure that they have that connection in the community still today, even though the community landscape of behavioral health looks a little bit different. As well as talking about the importance of, fulfilling your medication, making sure that they're still getting enrolled in Medicaid. So, I mean, we're doing a lot of efforts on the inside of the house, and just that education piece and that warm handoff is so important. And then trusting that our community partners are going to be there to kind of pick it up on the other end and engage them. So like the managed care plans couldn't have as much in-reach right now, video in-reach. And so they're making sure that they're really picking it up on the other side and reaching out. They're also looking at incentivizing some work within the managed care plans to maybe provide some gift cards and things like that. The Ohio Department of Medicaid is partnering with their managed care plans to try to keep those individuals engaged post-release. In this time when it's easier to kind of fall through the gap, we're trying to close that gap with all sorts of different strategies, both inside the fence and in the community.
So Kelly, when you were talking about the telehealth, and then you're talking about the SMIs, or for folks who, I'm not going to use it, for the seriously mentally ill, how's that work with the telehealth? Has it been successful on the outside, like getting them connected? So I know that the ideal of doing the community linkage is to ensure that they have continuity of care. So it's very difficult to have continuity care in a pandemic, right? When you're face-to-face, interaction has been limited, if not curtailed altogether. How's that connection? How's that telehealth with the community linkage piece? How's that coming together? Are you making sure that the individuals that are inside are telehealthing or making a connection via video or Zoom prior to release? Is that happening? Or how's that working? Can you elaborate a little bit?
Sure. And we do have our own lingo, Kysten, so I have to be really careful of that as well, because I start to speak in DRC speak, as we say, and I want to make sure that everybody on the call can understand what I'm saying. So when you said SMI, I was following along, but I'm glad that
I know you knew. Yes, I knew you knew. I wanted to make sure that our participants, our audience, was aware. You know, we often get into these dialogues where we start using, the jargon of corrections, and we often lose people. And I wanted to make sure I wanted to be cognizant that that wasn't happening.
Absolutely. So, one thing that obviously, I wish Perry were here to kind of speak to the community connection and what he's seeing on the community side. And, if any community providers are out there and they're seeing any trends, we would love to hear about it as well. So in regards to when we're preparing for release, we have both the community linkage for our seriously mentally ill, and that is not necessarily always an in-reach appointment. So what we're looking at more with those is setting up that initial appointment out in the community and kind of explaining how to access that, and then how to make sure that they're connecting. And really with OMAS, they're doing things that will promote that by providing, appointment reminder, by giving them paperwork before they leave so they know exactly what they're supposed to do. If we have what we consider to be like a hard to place individual or someone who needs extra supports, we actually come together as a multidisciplinary team, Kysten, with unit management, security, medical, the community linkage worker, maybe the parole officer, all of these people who are going to intersect in this person's care, and kind of talk about a strategic plan to make sure that they stay connected, that they get connected, stay connected, and keep thriving. And so we do that by, setting up all of these things and making sure that we really have thought about the person-centered approach. So what the director was talking about today, I'm fortunate to be part of the Office of Holistic Services, which for those people that maybe didn't get a chance to hear the director, is a new department within ODRC, and it includes education, religious services, recreation services, recovery, medical, behavioral health, quality operations, education. I have to go through it again. I think I said them all. Hopefully I did. Hopefully I represented everybody who's on our great team. And really that has started to focus our policies and our procedures on looking at it as a holistic picture of care. And so when we have those hard to place offenders, we're able to do that. Now, as for us always getting to see what happens on the other side of the fence, we don't always get to see that picture. We do get information from the Department of Medicaid. So if they're in the Medicaid pre-enrollment program, we actually can get some information back that kind of helps guide our practices and some things that we're doing to see like what else could we do to help them be successful. Obviously, if they're going to be on parole, we would be able to work with the parole officer on a plan, make sure that they were aware, and maintain the person in continuity of care. So we are doing all of the efforts that we can to ensure that that person realizes the importance of the continuity of care and the ability to engage despite the limitations of the pandemic.
Great. So I have one question that came in from Carlene Harrington. We hear horror stories of persons released from prison without their meds, without connections to get their meds or housing. Is this an anomaly, or how does this happen?
So I think that's a great question, and I'll speak to a little bit about what we do with meds, because I think that people need to know. So with our seriously mentally ill population, they're actually given 30 days of medication and then 2 scripts for their medications as well, in case they can't get in to see a provider in enough time. We want to make sure that there's no disruption in their medications. And then if they're SMI, they would get their behavioral health medications as well as their medical medications for that duration of time. If they are not seriously mentally ill, then you get 14 days of medication. And then you also can sign up for Medicaid, and therefore you can get in to see a provider and get your continuity. So we strive to get everyone their medication, and we try to make sure. So what would happen if someone left without getting their medications? Let's say maybe it was an immediate release. So maybe they get a lot of earned credit or something like that. They're a same day release, and we get last minute notification and we don't have all the medication in stock in our pharmacies, is we would actually order it. And if the person was close enough and they wanted to come back in, they could come to us and get it. We could call it into like the pharmacy near them for them to get it, or we could get the medication to them depending on how many days they already had. So there are mechanisms in place to get people the medication if they're missing their medication prior to actually going out of our doors. And usually we're aware of that because we are personally giving those people their medications prior to release. So I would say that that's an anomaly with the medications, and we definitely want to work with individuals to get their medications. So if you are working with someone in the community, or you run into somebody in your place of faith, or a neighbor or whoever, or someone that you're working with maybe in your organization, and they say something about their medication need, make sure that they're reaching back out to us, because if for some reason that there was a disruption, we would want to make sure that we remedied that. But we have quite a few processes in place to get people their medications if they leave prior to getting them. And usually people are leaving and we have advance notice, and we're getting those medications in place, and we kind of have a whole discharge process that we go through where you receive your medications, education, and you sign off that you received your medications. As far as housing, like I said, we have the hard to place committee that comes together, especially if we're seeing that someone who really needs housing in order to be successful is going to go into the community homeless. We do work really hard to try to get housing placements in place. But that is a huge community need, and something that we really work with our community partners on trying to secure more and more housing for our population, especially populations that people don't typically want to house, such as your arsonists and your sex offenders. We really need housing in place for those individuals who most people don't want to open their doors to, and housing really is a community project, I believe.
So what have you identified? Have you identified any new opportunities during the pandemic that were not necessarily in place because of, one, when you have a crisis, sometimes you have to think outside the box to be able to keep people safe and make sure that services are being delivered. So were there any new opportunities that the agency or the organization discovered during this? maybe during that period of time when we were in that rush to shut everything down?
Yeah, it's a great question, and I think so many people could speak so broadly about this, probably more broadly than I can speak within DRC. But and I know I've kind of highlighted them, but they fill my cup up. So I'm just going to highlight them again because I think there's such great initiatives. Medicaid has really been in our corner, for individuals who were COVID positive. They were what was called a critical risk indicator, which means they get that additional kind of linkage with their managed care plan. They're also doing those care kits for us, those backpacks that have the hygiene items on it and other things. They're looking at being able to supply the cell phones for us. And so I think that's another great initiative. Our OMOS partners have been so encouraging both on the substance use disorder side and on the behavioral health side in regards to just sharing resources and coming together and making sure we're in line steps. So when we were talking about the anticipated behavioral health surge that we continue to face as a community and nationwide, it's the same thing for inside, in our incarcerated facilities. We're going to see that same behavioral health surge. And so I think it's brought us all closer and made us just re-examine all of our resources to really show how we can work together. Our medical response has been phenomenal, and we've really been able to come out of this with some new ideas of how to expand services, right? Because by being able to do services during the pandemic, we have utilized some techniques such as telehealth, supplemental activities, different ways to do individual services, different ways to do our rounds, things like that, that actually we're increasing our presence in our facilities for behavioral health, recovery services, education. We are all looking at this differently. Religious services, recreation, as a holistic team, we're getting creative, which are things that we'll be able to carry forward. So it's kind of interesting now that we're done, maybe, or not done, because I don't think we'll ever be done responding to the pandemic. So that's not what I want to say, but I think we're not in that heightened sense that we first were, where we were all kind of scrambling and no one, we were more in that emergency stage of how are we going to respond to this, just like the whole nation was. We have been able to start to become proactive and kind of turn the corner on how are we going to continue to provide all of these great, robust services to this population.
So how critical has Medicaid expansion been to providing some relief or some services, some important services to the population, to the justice-involved population during the pandemic?
So I used to work really closely with the Medicaid project. I actually used to be over it in my former role, so that's obviously why it's near and dear to my heart. And it's so important. To be able to know that you have that, your Medicaid, your relationship with your managed care plan prior to release, and so that you can have that kind of natural transition and be able to access services, is really important. And also, the Office of Reentry does the SNAP benefits and things like that. So there's other things going on behind the scenes as well than just like the Medicaid resource. And I want to make sure I recognize those efforts as well. But, throughout this pandemic, we've added the COVID positive individuals to that critical risk indicator, as well as right now we're partnering on expanding it to include as an automatic qualifier for that, as well as intellectual disabilities. So I feel like Medicaid has really kind of been in our corner. They've helped us with, some other initiatives and some responses as well. And it's really all of our sister agencies. So, I speak about Medicaid because I'm knowledgeable and I have that relationship and that history. And obviously I speak about OMOS because, again, they're huge partners, of ours, and they're, inside of our facilities with us helping respond to this. And provide that great treatment that they're doing in the substance use realm. but it's really all of our community partners, everybody who stepped behind us and beside us throughout this, is just how we are coming out of this, stronger and, as the director said, just focused and really leveraging this as an opportunity instead of a barrier, that being the pandemic.
So if you could say that was something that individuals on this panel could do for you or the organization going forward, what would that be?
Oh, that's a really good question. I think the one thing is just building acceptance, building acceptance of those that we serve, not, and I know that everybody in this room, with us, or this space with us, understands the importance of that, but I think it's just worth saying again, because really, we're the lifelines of so you guys in the community are the lifelines of support to our restored citizens, and they deserve every ounce of your support, of your connection, of your healing, to really allow them and give them the opportunity to be successful. I think, if you have the opportunity to volunteer and come into our facilities, I know that that's a great way to serve while they're incarcerated. But if you just stand beside them, and stand beside us as an agency when, people are coming back into your communities, when they're your neighbors, when they're coming to your places of worship, when they're coming to your community agencies, it is just so important that we're not stigmatizing, these individuals, that we're coming from a place of, welcoming them and giving them the tools and the knowledge and the support to be successful.
Fantastic. So I'm going to open it up to the audience, to our participants. So hopefully we can do this. Not everybody unmute yourself at the same time, but if you have any questions that you would like to ask of Kelly, please ask them.
Kysten, while we're waiting for everybody to speak up, I kind of want to just emphasize one more point that I was just talking about.
Yeah.
Sometimes I think when we see people in the community, we are hesitant to help unless someone looks like they're in distress or verbalizes that they need assistance. And I think sometimes we need to realize, just like, like I think the Children's Hospital campaign has, kids won't wear their feelings on their sleeves, it's not always evident that people are in distress or people need help. And so I think we need to be proactive with our approaches with helping people in general, and asking people, and looking for those little cracks in people's, foundation, because everybody wants to be brave or do it by themselves or things like that. And we need to kind of look for that little glimpse that shows, hey, this person might just need a little knowledge boost here. Like we were talking about how to pandemic, how do you interview, maybe virtually, or how do you do your telehealth and things like that. So I think we just need to make sure that we're proactive and not always waiting for someone to come to us and want us as a resource. Hopefully all of you serve as a resource every day, and just know that you're making a difference no matter what you're doing, as long as you're doing it with a helpful heart.
Fantastic. So I have one question, since it seems to be quiet here. I have one question. I think maybe this may help someone. So what direction can you give our participants who may be or have a loved one, or maybe themselves, who are struggling with their health or their mental health issues during COVID? Yeah,
that's such a good question, and I definitely am thankful for the opportunity to speak to that. I think people, sometimes what happens is, we're so busy responding, right? So I know personally, professionally, it's been really difficult, and but sometimes we're so busy going through the motions and responding that all of a sudden, once maybe we have a little bit more time, or we're not as busy, all of a sudden, those are when you might see an increase in your mental health. So even though you might think, I'm actually in a really good space right now, it might be that you're so busy processing and managing things that you haven't experienced some of the anxiety or depression that can be very common during the pandemic. And so there's some great resources on the Ohio Department of Mental Health and Addictions services page in regards to COVID and kind of the emotional response to COVID and all of that. So I think that that's a great place to start with, as well as just making sure that you're reaching out and making connections, as well as practicing self-care. You know, sometimes the last people that we take care of are ourselves, right? Especially if you're in the helping field. But, you know, when you get on the plane, they say, put your air mask on before you put the air mask on of others. And that's because if we're not breathing, if we're not filling our cup, if we're not taking care of ourselves, eventually you're going to have nothing left to give. And that's going to make you, you know, unable to help others, which usually helps fill your cup a little bit too. So those are the things I would say. I would say reach out, stay connected. If you have loved ones who have mental health you know, issues, make sure that you're mindful of that. Make sure that they're making their telehealth appointments. Make sure that they're keeping those med scripts up because, you know, obviously that looks a little bit different in this landscape as well. Make sure that you're practicing self-care and make sure that you're just taking time and practicing grace with yourself because we're all new to this, right? And I haven't met anyone yet who is just pandemicking so well that it hasn't impacted them at all. You know, whether or not you've become a school teacher for your kiddos, whether or not you're trying to run the state from your bedroom, you know, whatever it is that you're doing, just remember to practice a little bit of patience with yourself and a little bit of grace. It goes a long way.
Well, that's great information, Kelly. I really appreciate that. So at this time, I'm going to be quiet for a minute, and I am going to open it up for questions. And I promise I won't jump in. So if anybody wants to ask a question. All right. Well, Kelly, I have a question for you.
Okay.
So, what lessons learned as far as the mental health field is concerned, and maybe even your connection with DRC? What lessons learned, or what critical issues were exposed as a result of the pandemic?
That's a great question as well. I'll take it from the behavioral health standpoint within DRC. You know, I think that, you know, well, I can speak for myself first. You know, when they first said, you know, we are kind of going to this, we're implementing this pandemic plan, you know, and we're gonna, you know, kind of condense down central office for incident command, and we're gonna send you home to work. At first I was like, oh, okay, I'll be back in a week. So I didn't grab as much stuff. So next time you get sent home, guys, grab all your stuff because it might be a minute. So that's the first lesson I learned, just personally, all jokes aside. I was like, I did not grab enough stuff.
Don't worry, I did the same thing. I was like, okay, it's gonna be 2 weeks, a month at the most.
Yeah.
So yes, I had to go out and buy supplies.
Yes. But, you know, I think the most important thing that, you know, we learned was, you know, again, the need to supplement care and to kind of figure out a way to stay connected. And there were some growing pains with that in regards to figuring out, okay, like, you know, how can we best support our field so that they're best supporting, you know, the patients, and figuring out those exact connection points that made sense. You know, figuring out, adding into the medical assessment if someone was COVID positive, some, you know, questions about, you know, their mood and how are they coping and how are they managing, so we could make mental health referrals for those individuals who were COVID positive in our system, so that we could make sure that we were seeing and connecting with them, because they, you know, if anyone has experienced it, there are, you know, a lot of psychological, you know, ramifications from having COVID positive as well, because maybe you're not sleeping as well, you're isolated, so on and so forth. You know, our facility did some great things with encouraging family connection and kind of looking at removing some costs and some barriers with that. And so I think, you know, we were constantly looking for what we could do, you know, and trying to get some services, you know, back up and running as much as we could. And so that's kind of the thing, you know, just staying connected, and looking at it from that holistic point of view, I think is so important, because, you know, you definitely throughout this pandemic could not operate in your own lane. Like, you had to be able to cross lanes. And sometimes I think, you know, we get such tunnel vision, right, on what we do. You know, I do this and I kind of put my blinders up and I get to it and I do my area. And I think even in the community, that's something, you know, we need to open up our blinders a little bit, because this has really forced us to all think outside of our box and all to lean on our neighbor, both personally and professionally, right? And so I think that that's for me what I enjoyed the most from learning about, was just how to make all those connections and how to really build my relationships, even inside, right? Like even within DRC, and then also with community partners.
So were there any gaps exposed that otherwise would not have been revealed but for the pandemic, as far as, you know, working in the facilities and how we provide care and prepare individuals for returning home?
Any gaps that were exposed?
Yeah, not necessarily that were pandemic related, but would not otherwise be exposed but for the pandemic.
Right. I'm really trying to think of like solid gaps. So we said, oh man, like I can't believe we never really saw that before. You know, I think it helped accelerate some things that were already kind of in the hopper, which is definitely helpful. I think it really got people to action on some items and to progress some projects that maybe weren't as close to completion. So I think that was really helpful. I really cannot think of a solid example for a gap that around reentry that we noticed that was brought up just because of the pandemic. I'll keep thinking about that one. If I think of something, I'll let you know. But like I said, I think what it did help was it was like an accelerant, right? Like all of a sudden we just kind of went into this mode of, okay, like let's put our heads down and get this done. And that was definitely helpful because we've been able to provide some things that we weren't providing in the past, some things that I've already talked about, but I'll have to keep thinking about that one.
I know, I threw you a curveball, right?
And usually I can think on my feet, but that one's, oh, it looks like somebody else has a comment. John. Yay, John! John's my counterpart in OMAS for substance use disorder. So let's see what he has to say.
Okay, I can't see it. Can you see it?
I cannot. It just says, oh, maybe it was just to me.
Yeah, maybe it was because let's see what's in the chat. Oh! All right. I think somebody has a chat, but it went up. David, I think, has a chat.
Okay.
Said something like, I know folks tend to wait until the last minute to take care. something's going on with the chat that is being cut off. So if David, if I mess up your questions, please give me grace and forgive, but I think it's cutting it off. So it says, I know folks tend to wait till the last minute to take care. I know some ODRC institutions have deeper support on the inside. Have they been using them with release? And I'm not sure. So if David, if you're on the call and that is not what you meant, can you unmute yourself and provide clarification on your question, please?
This is Ken. Yes, I was talking about peer recovery support.
Okay, so it did not even come in. Thank you, David. So would you please reiterate your question, please?
Yes, some of the institutions utilize peer recovery support on the inside. I was wondering if they were utilizing them with behavioral health upon release, helping them get connected to the services that they need to kind of close the gap between time span.
So David, that's a great question. Sorry. And we, right before the pandemic, we were in the process of kind of adding peer supports within behavioral health, and they were kind of looking at peer recovery supports within recovery. And I don't know, I know that John might be on. I don't know if he is actively on, or I know he's super busy. So I don't know if he has the opportunity to kind of speak to that as well. But we haven't fully implemented the peer supports. We're working with OMOS to be able to implement the same kind of curriculum that they have out in the community. So that way when people do get restored, oh, there's John, they can then be certified and be able to do that out in the community. But I have not implemented it on my side, but I can defer to John if he would like to speak about his side.
Hi, Kelly. I'm having a little bit of trouble with my Zoom, and so I'm not sure my question came through correctly. I'll ask that in a minute, but to answer David's question, and just to introduce myself, my name is John Sexton. I'm the Director of Recovery Services, the substance use disorder treatment within the Ohio prison system, and I work for the Ohio Department of Mental Health and Addiction Services. And to answer David's question on peer supporters, we were in the process between our two agencies, DRC and MHAS, of formalizing a certified peer program within the prison system. So they were going to be used in two different capacities, some with behavioral health services dealing with mental health issues, and some working as recovery coaches dealing with substance use disorder issues. We did have some trainings, and we were working to get that off the ground when COVID hit. And we have had to stop that because we could not bring in the trainers for peer recovery training. But it is our plan, as soon as we can, bring in individuals to train the offenders on peer support services, that we are going to do that. Now, we do, through the Department of Mental Health and Addiction Services, refer to peer supporter services when individuals are released from the prison facilities. And that is a voluntary activity. So not everyone who is released from a correctional facility does take part in or take advantage of peer supporters, but we have had great success with those who do take advantage of those individual services.
Well, Mr. Sexton, I appreciate it. Thank you. Anybody else have any questions or want to ask either Ms. Storm or Mr. Sexton some questions before we wrap up? I think you may be able to. So I have a question, Mr. Sexton. For purposes of of being able to train peer supporters inside of the facilities, is there any conversation around doing it virtually, or is this something that has to be done one-on-one?
Well, we have had some conversations about doing it virtually. A big struggle for us right now, our big challenge, is actually bringing the individual offenders who are in the prisons together to do some of that training. We have individuals who are interested in being peer supporters and who qualify to be in the training, but they are actually housed at separate facilities. What our intention was to bring all those individuals together at one correctional facility and host that training, and then begin to work with those individuals at that facility and coach them and supervise and mentor their activities. And then we were going to then transfer them back to other facilities across the state and kind of deploy that way. But because of COVID, our ability to transfer inter-institutional is severely limited right now, because we want to keep the offenders and the staff safe, and we don't want to have any possible carrying of the COVID virus back and forth between facilities.
Thanks. So I do have a couple of questions that were in the Q&A. So one question is, and Mr. Sexton, if you would like to stay on and answer these questions, that would be great. So I don't have to throw them all at Kelly.
Okay.
So if you know that an individual has a diagnosis who is returning to the community, what help do you have lined up to support their counseling and medication needs? And so I think we probably answered that, but Kelly, if you could just touch on that a little bit, just to reiterate.
Sure, I can touch on a couple of things. And John, I know I kind of wrangled you into this, and I appreciate you kind of being out there as a resource as well. You can definitely speak to some of the stuff that goes on in recovery, and maybe even touch a little bit on our medication-assisted treatment too, which people might be interested in. So things that we do to support their counseling and medication are things that kind of we talked about a little bit before. So I'll just briefly touch on mine, and that'll give John a little bit of time as well. And so, for those individuals who are on the behavioral health side of the house, we do discharge planning with everyone. So we're meeting with them, we're planning, and really, what you have to realize with ODRC is we have lots of tools in place where really our goal is to start treating, a person as soon as they enter into reception, to start putting them on a pathway for reentry, right? Like we want to start day one with working on what are we going to be doing to best prepare this individual to be as successful as possible upon return into their community. But as they kind of get towards the end and they're getting ready for that final piece of reentry, we're looking at, the community linkage that I talked about before. We're signing them up for Medicaid. We are meeting as an entire multidisciplinary team if they're hard to place. We actually engage family now for those individuals who are leaving out of like a specialized mental health housing unit. We call them and engage with them prior to release. And specialized mental health housing is such as like a residential treatment unit, which if you think of like an inpatient level of care, so it's for our more acute population, those people that are, a little bit sicker. And we also have day treatment programs that we would do that for as well as Sugar Creek Developmental. So that's for our individuals with intellectual disabilities. So we're reaching out to those families and trying to engage kind of the next of kin, whoever that's identified as. So for some people, that's going to be a family member. For others, it's going to be a support system. And then we do some stuff in the space of dual diagnosis and substance use. John, I don't know if you want to speak to that as well.
Certainly. Thank you, Kelly. Within the ODRC facilities across the state, we have substance use disorder treatment at every facility that is managed and carried out by licensed clinicians in the recovery services field. And those individuals provide a variety of programs that the offender can participate in for substance use disorder treatment. Much of our mainstay programs are an intensive outpatient program, which if the individual goes through all three segments of that program, it lasts anywhere from 5 to 6 months. There's also a brief intervention program that is a 7-week program. Both of those programs, IOP and brief intervention, focus on cognitive restructuring. It's all based on a cognitive behavioral therapy model and works to teach the individual to restructure their thinking, consequently their feelings and their behavior along with that as well. We also have had and are in the process of reestablishing therapeutic communities. These therapeutic communities are living environments where there is a structure to the individual's day and week, and they go through various treatment groups throughout that week, just like they would in intensive outpatient and brief intervention. With all of those, these programs will help qualify an individual for the community transition program. And community transition program is an activity that the Ohio Mental Health and Addiction Services Department hosts and will provide some recovery supports and services for an individual up to 12 months after their release. It will help engage them in further treatment if warranted, supportive services, housing, education, helps with transportation, and a whole host of other venues that we look at as recovery supports. Also, as Kelly mentioned, we do medication-assisted treatment. If an individual qualifies based on an opiate use disorder or an alcohol use disorder, diagnosis, they participate in treatment, they become eligible to receive medication-assisted treatment prior to their release. And we have chosen at this time to utilize an injectable form of naltrexone, which is called Vivitrol. And an individual can receive up to 2 injections prior to release from a correctional facility. And they'll get the first one about 30 days before they leave, the second one a couple of days before they leave, and then we also, through the Medicaid program that Kelly mentioned earlier, we have future appointments set up in the community for that individual. So hopefully that will, yeah.
No, I didn't mean to interrupt you.
No, you're fine.
I appreciate your comments, and I'm glad that you were able to step in and help Kelly out and really provide additional wealth of information for our session today. I think we are at I think we may be a little bit over our time. So I really want to thank Kelly for participating, and Mr. Sexton for jumping in at the last minute and providing a robust conversation and providing information. I hope that everyone is enjoying this Building Bridges community experience, and I hope to see everyone again. Again, thank you for participating, and for our panelists, thank you for a really robust conversation. Have a great afternoon, and I will see you soon.
Thank you so much, Kysten. I appreciate you.
Oh, no problem.
Thank you.